I'd like to thank the organizers for this opportunity to speak today. Monthly and every 2 monthly long-acting cabotegravir and rilpivirine was recently approved for the maintenance of HIV suppression and is now recommended by treatment guidelines. To inform use in special population, we considered factors impacting the absorption process, as well as the PK impact from organ impairment, growth and development, and reproductive stage. In the setting of organ impairment, we know that the process of long-acting drug absorption from the IM site of injection into circulation is not impacted by changes in metabolic or elimination capacity. So the recommendations in organ impairment were based on the no difference in metabolism and elimination profiles that we saw between the oral and long-acting formulations, as well as oral PK data and protein binding effects from studies with the oral formulation in hepatic and renal impairment studies. The effect of altered UGT metabolism on long-acting CABPK was evaluated in participants with poor UGT1A1 metabolizer phenotype. CABPK increased by less than twofold through 48 weeks, confirming that long-acting PK is overwhelmingly determined by factors affecting the rate of absorption. Similarly, polymorphisms conferring poor CYP3A metabolizing activity are not expected to impact long-acting rilpivirine PK. Extrapolating PK to children involves predictions based on their physiologic changes. So although experience with chronic IM or sub-Q long-acting injections are limited in children, we suspect changing BMI and muscle mass by age and gender may have considerable impact on IM drug absorption in pediatrics. Because of the potential factors for these to alter long-acting PK to a degree that we cannot anticipate, we've carefully designed our pediatric studies. In adolescents, where we're more confident that participants have predominantly small adult physiques, we've pursued a typical pediatric investigation, while in smaller children, we're designing studies to allow for participant efficacy and safety while we learn their PK, balanced with the need to acquire data quickly. In pregnancy, changes in body fat and BMI affecting long-acting drug absorption need to be considered, in addition to changes in maternal blood volume, protein binding, and metabolic alterations. Long-acting PK tails in 2 of 3 women discontinuing long-acting treatment at the start of pregnancy did not decline faster than what would have been predicted in non-pregnant women, suggesting pregnancy-induced PK changes may have less of an impact with long-acting injectables. So in summary, dosing guidance and the approach to ongoing studies in special populations have leveraged knowledge of the unique long-acting attributes of cab and rilpivirine, absorption considerations with IM delivery, and the data with oral and long-acting formulations as available. Based on oral PK, no dose adjustment for long-acting cab or rilpivirine is required in hepatic or renal impairment. Population PK modeling and consideration of changes in BMI and muscle thickness will inform dosing guidance in pediatrics. And finally, studies are planned to evaluate continued long-acting dosing during pregnancy in treatment and in PrEP studies with CAB monotherapy. Thank you again for this opportunity, and I'm happy to take questions during the panel discussion.